we don't look at the ratio, we go back to that FEV1. If you look at that FEV1, you come all the way across. This is the forced expiratory volume at 1 second, and we look at this number right here. And if the percent change is greater than what? It's reversible. So is it reversible? The end. All right. Next one is a 70-year-old male. So FVC, normal or decreased? Decreased. So we know we have either B or C at this point. FEV1, FVC, decreased or normal? So the answer is A, B, C, or D? A, B, C, or D? C. Good. Next. So this patient, we will send for Pulm PNTs. So we want to see what percentage of this is obstructive, what percentage is restrictive. And is it reversible? No. All right. Easy peasy. This is a 30-year-old female. Right away, we can already tell which one is it not going to be. I already know it's not going to be obstructive and it's not going to be mixed. So we're already down to 2. Restrictive or normal. Right? So pretty quickly, we look at actual, compare it to lower limit and normal.
Above. Normal.
I'm going to do this for one more second. Okay, I don't know. See, I did have one that was normal in there. Dang it. I overthink this. All right, so now we have an 85-year-old male. We already know that it's not going to be A or C. So let's go down and see if it's restrictive. So which number do we look at? FVC. We come over here. Here's lower limit of normal. And it's lower. So we have restrictive. Good. So that's just a quick. When we come back to this on a review, we'll do a couple. That'll just be a skill that I want you to be able to do. But it should be one of those where when you get to a part of the test where you have to do one, you should be like, let my brain relax a little bit, hopefully. All right, so 1.5 and 1.6, these are our lectures we're going to do today. And then I'm going to go to my daughter's band concert, straight from here. She plays the clarinet. It's awful. I'm just waiting for it. I remember my first band concert, it was like, we're getting ready to play, I was playing the flute, and just 1, 2, 3, and then we were playing When the Saints Go Marching In. And I couldn't even play because I was laughing so hard. Yeah, it was horrible, so I wish I could sneak in a few drinks before I went, but it's not going to happen. And I have to go in my uniform too, so that'll be fun. All right. We're going to start talking today about some things that we're going to be looking at from a clinical standpoint. We have done the review part of this course. Today we're going to talk about some common respiratory complaints. And this will tie into when you guys are doing your clin course. I think one of our cases that we use from Pulm is dyspnea. But this is where we can start talking about looking at pulmonology from a, what is the patient going to be coming in with? This is Colonel Cola's. I know we have Vindicate. We have all these different ways to build differentials. This is just my way. When I have a patient come in, very quickly, but first, are they going to be dead? Do I need to think immediate resuscitation? The second thing I think of is, is this something I don't want to miss? Just put it in your head. You don't have to work it up. So I always put cancer in this category. And I've gotten criticism because, ER docs especially will be like, why do you have cancer so high on your differential? I consider it, right? Back pain, it always could be cancer. So I just like to keep it up there, just to keep it in my mind. Because if all of this stuff doesn't work out, I don't want to take it off the table until I'm sure it's not that. Unless the patient gets better, then you're good. All right, so then we get to the common. That's what we'll talk about today. Common stuff. The most common reasons people have cough. The most common reasons they have whatever. Then we go to less common. Then you go to least common. Then you go to zebras. These happen on follow-up visits usually. You're not testing for everything under the sun at the first visit. You tell them what you think it is, you send them out. The If it doesn't get better, most important part about your treatment plan is the disposition. Follow up for this, come back for this. If it doesn't get better, I want to see you. If it gets better, it's probably with this, no big deal, but if not, come back and see me. And the fourth time, fifth time, you start thinking about those. Maybe it's Lyme's disease, maybe it's lupus, maybe it's cancer. So, maybe I need to refer them, right? Then the last two, these are ones in primary care that we saved for last. Even if I'm thinking psychosomatic or conversion disorder on the first visit, I had a soldier who was completely blind. Not blind, he drove his vehicle, but he couldn't see. I mean, he had a complete psychosomatic response to, I forget what it was something like, I think he fell out of cat's career course or something. But he would come into my clinic and he was, you know, he couldn't see. But anyway. But we had still to work him up, right? We still had to go through the motions. We ended up sending him all these specialists. And then before we diagnosed him with conversion disorder, it said this is not organic, because the last thing you want to do is tell someone it's all in their head and it's not. That is, does it happen a lot in medicine? Not a lot, but it's one of those things that you do not want to be on the other side of that patient. Telling them, I'm sorry, you've been admitted to a psych ward for a year because we forgot to check your TSH and you've been hypothyroid, right? Actual patient. So, secondary gain. That's a good one. That one you don't get to right away either. We all know those patients. We all know those service members. And it's on my differential every time. What does this person have to gain out of? But never on the first visit. You have to, every time that patient comes in, you have to start up here. That's why primary care is so hard and it's so voluminous, is that you always have to pretend the patient's dying every time they come in. You have to get their vitals, you have to get their history. Because this guy that's trying to get out of 16 PT tests, he'll come in with a PE. He will. He'll come in with something life-threatening, and you'll roll your eyes and you'll be like, I don't want to see him, get him out of here, and don't do that. Get a set of vitals, get your history, go in and see him, because those are the ones that'll sneak up on you. All right, these are the chief complaints we're going to go over today. Get a better understanding of when you have people presenting with these things. We consider these kind of the primary respiratory complaints patients will come in with. And then what you really want to do, at least in the context of this lecture, is it the lungs, is it the airway that's causing it, or is it something else? Is it something outside the lung? Is it extrapulmonary? Because shortness of breath has a very large differential that crosses a lot of different systems. All right, so first we're talking about cough. Cough is, again, we start with acute versus chronic. Again, we categorize medicine to make it easier for us to discuss things, to make it easier for us to create these algorithms. People do not read the book sometimes. So a patient that comes in with 2 days of cough may have a chronic condition. It's just the first time they've been seen. So again, interchangeable, but when we learn medicine, we have to start somewhere. We have to start with a reasonable differential that we can work in that 20-minute visit. So cough is normal. It is normal to have a cough. Someone coughs once, they're not dying. That is their normal physiological response to things entering the airway. So you get some stimulation down there, aspirate some, LaCroix, and you'll start coughing. Get something in that airway, you will start coughing. That is a normal response, like sneezing. You want to expel things out of that airway that's not supposed to be there. So we've got kind of these broad categories, and again, when we describe it as acute or chronic, when we start that assessment, when we do our OPQRST or our old carts or whatever, duration is important because it starts us down a different road in terms of what is in my differential. It doesn't mean that someone with a chronic cough can't have an acute explanation for their symptoms. It's just where we start. Why do we care about cough? It's annoying. It's annoying to our spouses, it's annoying to us, but there's also some physiologic things that can happen that we want to try to avoid. They can worsen reflux, cause headaches, dysrhythmias, so someone that's coughing a lot, and they've got, they're treated for AFib. Those things can cause, obviously the costochondritis. People eventually have chest wall pain because of it. So this is acute, again, less than 3 weeks. Number one reason, people get postnasal drainage from a cold. Similar things, right? Acute bacterial sinusitis, they've got a lot of stuff draining back down the throat, causing a cough. So most of the time when you have people come in with a cough, it's probably either going to be a cold or allergies. It's either going to be a virus or it's going to be allergies. When I talk about our force comm, our active duty population. This is a chart. Not something you necessarily need to memorize. I like algorithms like this because when I go see a patient, it reminds me of all the things I should be asking them, or what I should be thinking as I go in the room. You know, get your history, get your physical. Most algorithms start with that every single time. Get your history, get your physical. What meds are they on? Recent illnesses, exposures. What do they do for a living? What have they been exposed to? And then if it's life-threatening, obviously, out the door, get them onto extra higher level of care. If it's non-life-threatening, then we start to look into other areas. Could it be infectious? Could it be environmental? And obviously, this is why you get a medical history, right? You have a patient that comes in with cough. It's good to know if they have asthma, right? It's good to know if they have COPD, because that's going to change your course of evaluation and treatment. All right, viral, most common. Some sputum, they'll come in and say, no, I've been coughing. They'll say, is it wet or is it dry? They'll say, well, do you cough things up sometimes? Cough a little stuff up, it's not dry, it feels a little bit of wet. They're not really going to be complaining of severe systemic or constitutional symptoms, because it's a virus. You might hear some crackles. You might hear some noises in them, but if they cough, if they clear that mucus drainage, then it improves. So it's not a problem with the lungs, it's usually a virus that's causing postnasal drainage, or maybe a little inflammation in that airway. Not something you want to routinely get a chest x-ray for unless you are feeling extra insecure that day, or you have another reason that you think you need to get it, right? Otherwise, look for anything that might make you think that there's pathology, significant pathology in the lungs. A pneumonia, right? Again, we're talking about acute stuff, less than 3 weeks. So I'm not saying, we didn't see lung cancer in the differential. But remember, the information you get in the history is subjective. So sometimes people don't know that this recurring cough is significant if you don't specifically ask them. So they might have had a cough for 2 weeks, but really, before that, they were still coughing, right? And losing weight and all that stuff. So if you feel anything out of the ordinary, if they're not afebrile, normal vitals, not breathing fast, lungs sound okay, you don't need to really work them up. Don't need antibiotics, don't need a Z-Pack. When we talk about pneumonias, you'll see, we're creating these bugs that are getting smarter and harder to treat because we have overused antibiotics. Send them home, give them a little something to dry them up, or nothing, reassure them. Usually don't give inhalers unless they're coughing so bad that we think it might be beneficial. Typically don't give steroids, but after a week or so, Medrol dose pack, have I prescribed it for someone? Yes. It made them better, by the way. Steroids are great. You give someone a little Medrol dose pack. But it's really not necessary, because viruses resolve, and that's probably what it is. Big point here. This is one of the key points to treating primary care. Come up with a reliable follow-up. Don't say, come back and see me. Because if you're a service member, that means you go to the front desk and they tell you to pound sand. That means you call the clinic and you're on this rotating thing. Make a good follow-up plan, get them on the schedule, get them on the books, tell them if you don't need it, cancel. But get them a follow-up. The better follow-up you coordinate with them, the less likely they'll need it. Oh, I got better, you were right. A day later I felt better, it's resolved now, good. So that one's off your plate. All right, so this is a category that we call subacute. So between acute and chronic, there's something called subacute. That means it's been going on a little bit longer than we typically see viruses, right? Allergy seasons. An allergist I work with, she would tell people to go on allergy meds for 2 to 3 weeks. Just go on them, because once you hit allergy season, that's about how long it takes for those, whatever's in the air to, so you don't start taking Allegra once and then you don't take it. Take it for 2 to 3 weeks. We do the same thing with asthma treatment. So take it for about 2 to 3 weeks and then try off of it. So after that, we're not technically into the chronic, we're kind of an in-between place. So one of the classic associations with this time frame is what's called tussive syndrome. So a lot of times it's a patient who has had some sort of infection, influenza, pneumonia, some sort of more significant infection, and they're continuing to cough well beyond, that few weeks that you would take to get over something more or less severe. A patient I had come in, they had been hospitalized for pneumonia. It was about a month later, and they were still coughing. It wasn't getting worse. They weren't continuing to be febrile, but they were just still coughing. So first thing I did was get a repeat chest x-ray, right? Make sure that whatever they were on, make sure that pneumonia resolved. Make sure that pneumonia wasn't covering up a little something in there, like a granuloma or a nodule. And in these cases, you can consider giving them an inhaler to help calm down that airway. So obviously you're looking for all of this stuff. We'll talk a little bit more about other causes of that, and then you're considering these. I used ipratropium for this patient. Again, now we're saying up to 8 weeks. As long as they're doing well, come back and see me. And then we have chronic. So chronic is defined as greater than 8 weeks. Usually by the time you get to chronic, the patient's probably been seen between the beginning and now. And hopefully, you have thought about these things prior to that. You don't want to see a patient at 7 weeks. They've been having a cough for 7 weeks, and you're like, well, come back and see me when it's 8 weeks, and then we'll talk about these things. You don't want to do that. So use your judgment. So think about these things. There are chronic, I don't know if ENT covered some of the chronic rhinosinusitis conditions. Asthma. So if you have someone with a cough for more than 8 weeks and you haven't worked them up for asthma, you probably need to consider signing up for PFTs. We've got these things called ACE inhibitors, I'm sure you've learned about. Common side effect for ACE inhibitors is a cough. I didn't see it a lot, but I saw it pretty regularly in primary care. Not regularly. I probably had about 5 patients that had the symptoms and had to be transitioned to another blood pressure medic. And then GERD. So GERD, some of the response things run aligned with the trachea and the bronchi, and so GERD can present as a chronic cough. Usually they'll have more than just a chronic cough, but again, that's why when you work someone up for a chronic cough, you have to ask about those types of symptoms. So most common, according to current, right, according to your reference, postnasal drainage, asthma, GERD, and medications. And then some other ones at the bottom. Something in the environment. So timing of the cough is important. Some chronic medical conditions. So social history is important. Demographics for the patient. Is it a 14-year-old male who's never smoked? Or is it a 62-year-old male who smoked a pack a day since he was 10, right? So knowing the demographics of your patient will help you work through that differential. This is FYI, something to look at. I love pulling these up because I hope that you're willing to go and pull these up when you have a patient in phase 2 and you're going to see them for cough. I hope that you use the available tools to make your interactions with them more efficient. Up to date. Yeah. And I just like that because that's why when I was out in the field, that's the one thing I downloaded before I got out there. I was like, up to date. Because in primary care, you see everything. You just see everything. The jack of all trades, master of none is what they call us. So you're going to have to be reminded. And don't think that that's beneath you. Because you're actually providing better care. Because every once in a while something will pop up and you're like, I didn't even think about that. Alright, so postnasal drainage, this is the most common. Anyone that sees clinic will tell you that when someone comes in and they're like, I've been coughing for a month, I've been coughing for 2 months. A lot of times, we will identify some sort of chronic allergic condition, something that is causing postnasal drainage. When I do my physical exam, I know you guys are taught to do heart and lungs, but I have a routine where I pretty much do the same thing every time, depending on the chief complaint. Where I'll look, eyes, ears, nose, I'll look in the back of the throat. I will take the patient's nose, almost every patient, even if they're there for anything, and I will look up into their nose to look for any erythema, edema. And it's just something that I've gotten used to. Because when you tell a patient who's had a cough for 2 months and it's postnasal drainage, they will tell you to pound sand. They don't want to hear that. They want to know what's wrong with them and fix it, and you're like, you have postnasal drainage. It might be allergic, it might be something else, but the answer isn't, you know, you have lung cancer. The answer isn't, you know, you have something that we can give antibiotics for. It's that you have mucus running down the back of your throat and it's making you cough. So when you have a patient like that, a powerful tool is to pick their nose up and go in there and look in there and make a big deal out of it, even if it's not terrible. You see erythema and edema up there, if you see something in the back of your throat, you know, be like, whoa, okay, yep, I think I see the problem. And for some reason that gives you a better buy-in, and they're more willing to be compliant with what you're going to tell them to do. There's a little mind games in there, versus just sitting there at your desk and typing and be like, it's probably postnasal drainage. There's something about, you know, but if you don't see anything, don't make it up, right? If everything's completely normal, right? And it's like, no, you're missing something terrible. But if you do see a lot of mucus down the back of the throat, at least you can reassure them, because if they don't treat it, if they don't use the medications, they're not going to get better. So you got to get them to take it for a while to prove to you and to them that Flonase isn't going to fix this. And again, once they start taking it, you put them on it, you say take this for 2 weeks, at least. Don't take it for 1 day and then say, you know, it worked for like 6 hours and then it stopped working. It's like, that's because it wore off, right? All right. Then we have asthma. I'm not going to talk about this one too much, actually, at all, because we will have a whole lecture on this next week. GI covers this. Again, I'm looking at it in a pulmonary standpoint, as when a patient comes in with what's considered a primary pulmonary complaint, which is cough. You should have this in the differential. So you should ask about other symptoms. Do a full GI review of systems. Right? Do a full HEMT review of systems. There are certain chief complaints where you have a headache. Do a full neuro review of systems, right? You have knee pain. Do a full musculoskeletal review of systems. So pertinent review of systems when it comes to cough should include GI and ENT. All right, and then the ACE cough, and you guys are tracking, right? Give them a PPI. Okay, this isn't GI, I know. So we have an ACE inhibitor. We learned about that several times. You get that dry, non-productive cough. It's described as an annoying tickle. The timing can be tricky. Usually it's correlated, but sometimes they can be on it for a long period of time and then they'll develop a cough. my recommendation, if you're not sure and you think two things might be going on, just do one at a time. Don't stop the ACE and put them on a PPI, right? If it's tolerable and you think they might have some GERD, put the PPI first, give that a few weeks, have them follow up, and reassess. So if they're doing great on the ACE, try not to take them off it if you don't have to. So try all the other things first. And then if they come back on the PPI and they're still having a cough, then consider the ACE. Shortness of breath. So this will be, probably most of you will do this in the junior clinic court case. Lots of things. This is like chest pain. This is one of those where when we talk about the mortality, the high mortality things, there are a lot that can go into this, right? There's, acute causes of shortness of breath. In the bottom right-hand corner, I put some examples of emergency room presentations, and what people are presenting with. COPD exacerbations, heart failures, pneumonias. So it's generally a mixture of cardiovascular and pulmonary conditions. People will come in and tell you they're short of breath, right? So this is the definition. It's like dizziness, though. You have to qualify it. You have to quantify it. You have to get a little bit more information about it to understand what's causing it. This is the big, so what? When you talk to a patient and they come in and they say short of breath, you have to kind of think compared to what? How acute compared to what? I'm short of breath. It started immediately while I was running. I felt a sharp snap in my chest and now I'm short of breath. Versus, I failed my run, I need a medical reason to get me out of this failure, and I was, I couldn't breathe. So just qualifying it. A person who's got lots of comorbidities, they smoke, they're 50, they're 60, and they say they're short of breath, versus a young, healthy person that has acute onset dyspnea. Just watch out for some of these acute things that we really need to be thinking emergency care for them. So here's some variations of dyspnea. Shortness of breath, right? Because you're breathing too fast. If someone's breathing too fast, it's usually not associated with a pulmonary disorder. If they are hyperventilating, sometimes it can be a psychological disorder. Sometimes it can be like that Kussmaul breathing we talked about where someone's acidotic. But it's rarely a true pulmonary disorder when someone's hyperventilating. And then we've got orthopnea and PND, paroxysmal nocturnal dyspnea. And these are more closely associated with cardiac conditions. So when you qualify the shortness of breath, this is what you're really thinking about. When do you get it? What's it associated with? It'll help to give you an idea of where things need to fall in your differential. Because the differential is huge, right? And so you need to be able to organize it. All right. So when you get a history, you want to make sure that you're asking qualifying questions. Is it associated with exertion? Is there any edema, orthopnea, right? That leans us more towards CHF. Does it impact your activity? And how much? Any recent trauma? Any associated symptoms? In our past medical family history, we're looking for any kind of history of existing lung disease. That's very important. Do not forget to ask that. Shortness of breath in a 35-year-old asthmatic is very, very different than shortness of breath in a 35-year-old otherwise healthy person, right? So we just keep in mind, it's very important that you understand what their medical history is. Medications, obviously we talked about beta blockers, we didn't talk about beta blockers. the beta blockers can be one of the medications that can cause bronchospasms. Also, making sure that they're on their medications. So they say they have asthma, but they're not taking any medications, right? Allergies, and then obviously, do they smoke? That's huge. We'll talk about occupational lung disease. What have they been exposed to? We talk about things like asbestosis, silicosis, which primarily present as shortness of breath. Some physical exam stuff. I'm not going to go through this with you, but these are all things when you do your ClinCore on dyspnea. Don't be afraid to use these slides because they will help you to understand, like, well, which parts of the, do I do a full review system? No. You don't need to do a full exam. You don't need to do a knee exam, but you should look for edema, you should look for cyanosis, things like that. So again, it always starts with a thorough H&P. Who are you? What have you done to your body? Including where have you worked, what you've smoked, what you've been diagnosed with. And then, obviously, EKG, chest x-ray. If you ever worked in an ER, or when you do ER rotations, those are pretty basic things that we get every time. CBC, CMP, pretty basic things. And then additional. FYI, don't memorize this. Just understand that when you have a patient that comes in and they say, hey, I want you to evaluate that patient. Oh, what are they here for? Are they short of breath? It's nice to just have something, because even the most experienced clinicians, unless they do this a lot, will have to come back to some sort of checklist to make sure they don't miss anything. All right, coughing up blood. So we've got true hemoptysis and pseudo hemoptysis. People will come in and be like, oh, I'm coughing up blood, or my child coughed and blood came up. That is very disturbing to people. If it comes out of their mouth or if it comes out of their butt, people will come in and see you and they will be distressed. They will bring it in for you to see. They will bring pictures in for you to see. I don't need to see that, but it's important, right? There's true hemoptysis. That means it's coming from the lungs. It's coming from the parenchyma of the lungs, like in pneumonias, TB. It's coming from the bronchioles. Remember, when we get down to the bronchioles, then we have more innervation, we've got more, there's musculature in there to help with the bronchoconstriction, so there will be some bleeding. And then we have something called pseudohemoptysis. So blood's coming from somewhere else. Right? Nosebleeds are common. Kids get nosebleeds a lot, right? 5 most common reasons kids get nosebleeds, right? 1, 2, 3, 4, 5. So that, you know, if you have a patient, and especially parents bring, they say they coughed up blood, you want to do a thorough ENT exam. All right, here's another picture, right? What do we start with? History and physical. Look at the patient. They're healthy. They're otherwise healthy. We're not worried about tuberculosis. We're not worried about carcinomas in a 5-year-old boy, right? Could it be a carcinoma? Hell yeah. But we're not thinking about it, right? If they're otherwise healthy. It should probably go away. All right. So chest x-ray. Only if we have failed to demonstrate that the blood is more than likely coming from a nosebleed or more than likely coming from somewhere else, not the lungs. All right, so chest wall pain. So we've got our chest wall. I'm an osteopath, and everybody knows that. But I'm like I love when chest pain comes in, especially when the patient's stable. Chest wall pain is a real thing. You've got the ribs, you've got the intercostal muscles. You can get a lot of dysfunction in your chest wall. You know, when you do this and you hear things pop, right? Muscle spasms. Things get out of line a lot in your chest wall, especially if you're coughing a lot or you're doing some sort of exercise. So when you have a patient come in with chest pain and they're otherwise healthy and they're not tachypnic and they're not tachycardic and they have a normal blood pressure, You don't necessarily have to get a chest x-ray and call 911. You want to listen to their heart, you want to listen to their lungs, you want to look for edema, you want to assess them healthy. But the one thing you don't want to miss is to palpate the chest wall, right? Feel it. Push along the rib cage. Push along the spine. Touch it, because if you can reproduce it, it is palpable. That is good. You document that, reproduce it. You know, I hit on their first rib and they're like, oh yeah, that hurts a lot. Or I went down their, not vertebral angles, costochondral, whatever, and they said, oh yeah, that's really tender there. And as long as you can reproduce it and palpate it, that's great. Document that. You don't need to chest x-ray them, you don't need to EKG them. More than likely, it's either from trauma or from chronic coughing, where they just have some chest wall injury. Something else, if you go a little bit deeper than the chest wall, is the pleura. Unlike the lungs, the pleura is innervated. So when people have pain, they can have, we'll talk about pleurisy in a couple lectures. So people in general will come in, and it's usually when they're taking a big breath, because as soon as they do that, those lungs approximate to that pleura that's irritated or something else is going on with it, and that's the timing that they'll have with the pain. It's not when they push on their chest wall, it's when they're at the top of their inspiration. And we'll talk about pleurisy in a subsequent lecture when we talk about pleura and pneumothoraxes and all that, but the only time you really need to be concerned about that is if it's localized. If they kind of feel it all throughout their chest, less likely we're worried about a malignancy or any kind of abscess. But if they fit the profile, if they're a 71-year-old female who is 80 pounds and smells like cigarettes and hasn't had a chest x-ray and is complaining of chest wall pain, probably shoot a chest x-ray on her. You can have diaphragmatic pain, so you can't injure or pull your diaphragm. People get cramps in them. That pain typically will refer to the shoulder. But do a thorough history, do an abdominal exam, make sure everything else is normal. And then mediastinal pain, deep, central, sometimes it's GERD. Probably, depending on the patient, probably going to get a chest x-ray if it's central. You can't reproduce it, it's not palpable. I would think GERD, but if you put them on a PPI for 2 weeks and they don't get better, maybe you need to look at the mediastinum itself. Cool. Oh, phew. That was on the hour. All right, take a 10. Come back at, all right. So we're like halfway through block 1. Kind of cool. A little bit over halfway. Oh, it's not bad, right? We're gonna do, it won't be horrible. This lecture, we're gonna start seeing the pants blueprint sign pop up a little bit. These are all going to be topics that you're going to be responsible to know some aspect of on the pant. So just to keep that in mind, we're getting into that. These are, so we're, like we said, we're starting anatomically in the airway. We're in the bronchi and the bronchioles. We're in the upper airway. So we're talking about things like stridor. We're talking about things like bronchitis, bronchiolitis, laryngitis, right? Not laryngitis, that's the So, but we're talking up in the upper airway. Asthma and COPD will be separate lectures, as I keep saying. So this is kind of everything else that involves the upper airway. Foreign body aspiration, epiglottitis, croup, bronchiolitis, which is kind of synonymous with RSV. These two, these three, these four, probably almost all of these, you will see again in peds. So this is the first time you're seeing them. Maybe you will see them again in peds. Ideally, what major or Colonel Klein, major promotable, and Klein and INTs are similar. It's happened before where we have different stuff, but I think we fixed all that. That is medicine, right? Depends. All right, so let's get going. Foreign body aspiration. Again, this is a pants. Which is this the left or right? Right, who said left? Who said left? I have a brainwash here. Right, I heard left over here. Alright, so foreign body aspiration. When we do Peds Well Child, a lot of what we do is education. And when they're a certain age, a lot of what we do is to keep this from happening. So foreign body aspiration, we talk about it, we teach about it. It still happens. Those little teeny tiny airways are a little bit scarier than adults. But aspirating a foreign body can be potentially life-threatening. So we want to obviously prevent as much as we can. When it comes to risk, these round, solid objects tend to cause more problems because they fit nicely into those round airways. Infants and toddlers, more likely we see food items. As kids get a little older, they can move around and they can open drawers and they can get into things. We more commonly see toys, coins, hardware, things like that. So the big learning point here is it depends on where the foreign body ends up. And that depends a lot on the diameter, the size, the shape. Classically, when someone gets something into their airway, we've already talked about this, the body's first response is to start trying to cough. Whether it's solid, liquid, whatever it is, initially the patient is going to cough. So not to say, if you get a history on a patient, and there's no history of the patient having an episode of cough, the likelihood that they aspirated is probably low. So typically, they're going to have cough. Now, if it's in the upper airway, we might also, and it hasn't completely obstructed the airway, it may cause stridor. So we can hear the air moving around that object in the upper airway. I almost died on a Nacho Bel Grande once. I was eating it so fast, and I had like a whole chip in my airway, and I had to like crush it. It was pretty scary. Like I was breathing around the chip, and like crush this chip, and coughing all up. I think the boy was there too. It was so embarrassing. Smiling at him. All right, Nacho. So anyway, so we get to hear these three areas. So if it gets down to the lower airway, you probably will just have a history of initial choking and coughing. And then as it gets down into that area, so say it's a small enough object that it makes its way down into the small bronchioles. You probably, the patient might not be, gasping for air, you might not hear stridor, you might not see that choking response or that coughing response. Moving up to the middle airway, if it's in the carina, but it's again still letting air, or again it's in that right mainstem bronchi, it's going to be very irritating. Patients will be coughing. You may even hear a little wheezing when you put your stethoscope on them. And then obviously, if it's in the upper airway, you can hear the air moving around it, but God forbid, the object has lodged itself where the air can't move around, and then the patient goes into respiratory distress. Here's another picture. Key point here is we have all this workup down here on the left side. Don't forget, please don't be worried about consulting pulmonology or getting the patient down to a CT, right? If you think that there's an obstruction that's possibly going to occlude an airway, remember, don't forget your BLS. I know we have all these great tools, and especially when we get in the hospital, we feel like we're in this bubble, but do not forget BLS. That's the whole point of this. All right, so there's two types of patients that are going to be encountered in general, because right, we have to categorize everybody so we know how to teach this stuff. If we tried to teach every nuance of it, we'd be here, you know, for years, right? But generally, if a patient's stable, stable is three things to me. Anybody guess what they are? Three things, objective things. When I look at a patient, I look at three things.
Blood pressure.
Vital signs. Number two. Huh? Appearance. Does somebody say appearance? And then the third one, mental status. Who said that? So if they're mentating, if they look like they're not in distress, and if I can get a decently normal set of vital signs, to me, oh, I've had goosebumps. Good job, you guys. No one's ever done that. But that's just my thing, so this is disclaimer, right? In general, if I can say yes to those three things, then I can say stable. Not healthy, but stable. If that cannot change quickly, hell yeah, right? But in general, I'd say stable. All right. Now, if the patient's stable and they come in and they say, I inhaled something. Get your history. Did you have initial choking? Yes. Good. Little kid doesn't know that to the parents. Did they choke a lot? Yes. Okay, but they're normal now. Maybe I hear some wheezing, maybe I don't. But if there's a high suspicion, then you do the exam, you listen for wheezing, stridor, get the pulse ox, all that, and then you can do a chest x-ray. That will only show radio-opaque things, right? So if you're really concerned, really good history, really reliable, then you probably want to consider CT after that. Because these things, especially this one on the left, will form these nasty, nasty abscesses if they're in the lungs and we don't identify them. If we have low suspicion, you know, I think you will have people, right? I think and do they cough? I don't really hear them cough, but they've been completely acting normal, and their concern is based off of something that clinically you're like, well, it's very low suspicion, you're a new parent, you're worried. Like my sister-in-law one time, her daughter my niece falls off the bed onto a carpet. I don't even think she cried, but she was so freaked out, she brought her to the emergency room, and she was so scared that she ran in with her and tripped. She was bringing her in. Nothing happened to my niece, but I thought, oh my gosh, that was my sister-in-law. Trips and like dropped her on the floor. So, but some parents, right, they think that they swallowed something and they may come in. So if there's a low suspicion, you have a totally normal exam, go ahead and do the chest x-ray and then have a follow-up. Follow-ups are great. Again, want to make sure they're following up, just to make sure, you know, you see them a week later and you get a vital signs on them and now they got 101/10, right? We may have missed something. Just some pictures. We'll go into that. One thing I will tell you is PEDS airways. In EMED and major decline, we'll go over this a lot more. PEDS airways are much smaller, so that's why kids are much higher risk for upper airway obstruction. So I mentioned this in the beginning, don't memorize this, please. You will revisit this. This is AAP's recommendations for choking. You want to start at 6 months or whenever a kid can pick their stuff up. So a lot of your physical exam, a lot of your well babies are to get them vaccinated and to educate, because you're not really doing anything else. All right, epiglottitis. So Major Klein will go over this next semester. Obviously this is something we're going to cover as well. So epiglottitis, we all know where the epiglottis is. It gets infected and it swells shut. How are kids gonna, or what causes it? Usually it's virus. We've got group A strep also that can cause it. Inflammation of the epiglottis. The Hib was a classic culprit before we started vaccinating. And the Hib would cause very severe disease in kids. So you imagine you've got this epiglottis, right, and it's becoming swollen. And imagine, you know, the first thing that you're going to probably experience. And now you're not an adult, maybe you're a kid, so the kid's not going to say, you know, I feel like there's something in my throat. But you may start to see things. You may start to hear things. You may start to measure things. Depending on how, you know, as a parent, I was kind of like, they're fine, right? Depending on how long they wait to seek care, or if they go in early and they see primary care, and primary care doesn't do a good education or follow-up, or this wasn't even in their differential, right? The kid came in, he had a low-grade fever, he was coughing. They don't look at his epiglottis, right? They look in the ears. They may send them home and say, you know, use some Tylenol, wait 4 to 5 days. So depending on when you see them, you know, these kids may have progressed to more severe disease where, you know, the epiglottis, maybe not that swollen, but pretty swollen. If the patient comes in and they look like remember I showed you that picture in the beginning of someone that was using their accessory muscles, leaning forward, tripoding, they talk, they have voice changes. Be very gentle with these patients. Those airways can close up pretty quick. So we want to just be very gentle. I would not recommend, unless you have no other option, trying to manage this in the outpatient setting. Get them to an emergency room. So we'll talk about what's called the thumbprint sign. That's going to be a buzzword that's going to go with epiglottitis. I'll show you what that looks like. If you see thumbprint sign, or if you see that image, that'll be a clue that we're talking about epiglottitis. Obviously, gold standard is to look at it, visualize it. Important, maintain the airway from O2. Whatever air is able to pass, you want to supplement that a little bit. And then antibiotics. During the review, I will not ever make you know a dose, but during the review, I will let you know which antibiotics you need to memorize. I really only test on antibiotics that, because this is what the PANTS does, that are ones we have used forever, right? That aren't going to change. That there's not going to be 17, because when we talk about pneumonia, right, I can probably pull up 8 different, depending on the organization, on how you pick the right antibiotic. So I don't want you to memorize anything because it's really going to depend on a lot of things when you choose that. We'll stick right here, right? We talked about HIB, we talked about strep A. Ceftriaxone is going to be 3rd generation cephalosporin. It's going to be included in that in most cases. If everyone can see that, looks like a thumb pushing into that, across that airway. So patent airway here, the little dark spot, and then that inflamed epiglottitis. Croup is our second one. Make your little cheat sheets, your little study guides. Croup equals parainfluenza virus 1. That is the most common cause of croup. It's not synonymous, but for test purposes, it's synonymous, right? So what do you want to know? So classically, barking, seal-like. Does anybody have a kid that's ever had croup? So it's right. It's a weird sound. It's a very loud, it's a very unique sound when kids have croup. So it's going to affect the larynx and the subglottic area. So again, as we're moving down anatomically, we started with the epiglottis. Now we're moving down to the larynx and subglottic airway. So it's going to create some noises. It's going to affect voice. Typically, kids will be sick for a couple days, and then after about 2 days, then they'll start doing the weird cough, the barking cough, the seal-like cough. Usually it's self-limited. We'll talk about the or the treatment after this. So when I worked in the Marybridge ER, the pediatric ER up in Tacoma, we had saw so much croup, and when they would come in, we'd evaluate them, and then I remember that ER doc every time would tell the parents, okay, go home, maybe they give a little steroid, and then he would tell them, if they start coughing and you're worried about them, coughing too much or not being able to breathe well, put them in the car, open the windows, drive them up here, and if it calms down by the time they get here, you can go home. So this isn't one of those where you should be worried. You don't need to hospitalize patients with croup, but there is some risk just because of where the inflammation is. Those little tiny airways can become obstructed more easily than adults. And this, not the thumbprint, but this one's called the steeple sign. Steeple sign is, the x-rays are not routinely done for this because in most cases, you can make this diagnosis clinically. Just so you know, this little narrowing, this little dark area right here, so this is the inflammation caused by that parainfluenza 1 virus. Usually self-limited. Go ahead and go home. Give fluids, give rest. The tricky part about croup is when they present, when you educate parents, part of your disposition, right? Part of your treatment plan is educating parents. You want to make sure they know that if the coughing started around here, they are still probably going to develop worsening symptoms or have symptoms over the next 2 to 5 days. So usually they'll come in right here when that barking cough starts, or they start to have the hoarse voice, or they pop a fever. And if you're considering croup in your differential, we just need to prepare parents that for the next 48 hours it might get worse. And if they know that, it just helps to manage our expectations. And have them come back and get them kind of through the hump. If we see them in the ER, I'd say about 50% of cases, we would give a single dose of oral prednisolone to. Now, what was that based off of? I have no idea. Right? Maybe some comorbidities, maybe the severity of disease. Usually I forget with the parents. Felt better if some parents are like, no, if we did it, it's group, our other kid had it, that's fine. And then sometimes, just to help with the stress, because the caregiver, we still need to make sure that would help to decrease some of these symptoms over the next 48 hours. Okay, bronchitis. So, lower respiratory tract infection. Bronchitis is a very common ICD-9 code we use. Inflammation of the bronchi. So everybody knows what itis means. Anytime you see itis, epiglottitis, it means inflammation of the epiglottis. Bronchitis means inflammation of the bronchi. So, involves the bronchi, makes up about 10% of outpatient visits in general, depending on the population you serve. Most of them are viral. Bacteria are uncommon. A lot of the cases that I've diagnosed, in fact, most of the cases that I've diagnosed, just bronchitis. Usually it's post-nasal drainage. Usually I just write cough, right? That's a diagnosis. But when I've actually said bronchitis, I give that one to smokers usually. So, and this feels kind of like viral when we talked about cough, remember? Kind of feels like a virus, not a lot of fever, they have normal vital signs. Usually you don't hear anything significant, you're not hearing any crackles, you're hearing air moving in all quadrants. So typically you don't need a chest x-ray. The only time you consider a chest x-ray is if you're thinking pneumonia. We'll have a full lecture on pneumonia. It's our first lecture in block 2 on when you need to suspect pneumonia. So typically self-limited. And you follow them up. And if it doesn't get better, 1 to 3 weeks, depending on what their symptoms are, it's usually cough. Then you're in the subacute, right? Then you go into chronic. Then you start asking other questions. Then you start thinking, all right, it's been 3 weeks. Maybe I need to get a chest x-ray just to make sure nothing else is going on. And oh God, please stop smoking, right? That's so frustrating when people come back and see you for respiratory complaints and they still smoke. You're like, really? And then they yell at you. All right, now we're down to little bronchioles. So remember itis, inflammation of the bronchioles. A common cause of this is going to be our RSV. Very, very common. It's a seasonal, just like the croup, so you'll see it in seasonal clusters. You can actually test for it. So typically what we'll do and what most pediatrician protocols will call for is to test in the beginning of the season, and then once you get a couple positives, then you stop testing. Then there's just the assumption that the rest of the kids that come in have this. Wheezing. So wheezing, remember the bronchioles, we talked about anatomically. So wheezing, bronchioles. Guess what else affects the bronchioles? Asthma. So it makes sense. When we hear wheezing, not every time, because we won't read the book, but wheezing is usually pointing us towards bronchioles, the small airways. So thinking about things that affect the bronchioles and the small airways, those are going to be our asthma, that's going to be our bronchiolitis. Very forceful cough, blood-streaked mucus, and would this blood be true hemoptysis or pseudohemoptysis? True. Yep, true hemoptysis. Just by definition, these are definitions, right? It doesn't mean anything clinical. We're just testing it. All right. Again, self-limited. The one thing that I've always really noticed about these kids, yeah, they'll have a low-grade fever, maybe they'll have other symptoms, they'll not look well. But what I started to correlate with it when I saw a lot of peds was this river of clear mucus down both. They're just, you know, they come in and there's just a ton of mucus. And it just keeps running, which makes it nice because it's a nasal wash. Those are really easy to do. But lots of mucus. They're just full of it. This one is self-limited. I've had patients hospitalized for RSV when it becomes really severe. Usually those patients have comorbidities, or they're having trouble, or they don't have a good home situation. But in general, you can reassure most parents this will go away. But it takes a while. And just like the croup, if we give steroids, steroids help symptoms. Because when a patient comes in with some sort of infection, most of what they're coming in with is because of what their immune system is doing to respond to it. Make mucus, inflame itself, spike a fever. So everything that they come with complaining about, which is why they go and get seen, is because of their immune system. So giving ibuprofen, giving steroids, that's going to help. It's not going to help them heal, right? So we don't want to use them too much. My husband's a classic, just let them have a fever, and we fight about it all the time. We'll just let them cook it out of their body, and I'm just like, no, I'll just wait till he leaves. So, but truly, it makes them feel better. It gives the parents a little bit of a rest. It gives the patient a little bit of a rest. They can sleep for a little bit. You have to use your judgment. You don't want to be giving steroids for everything, but they do help, and they make people feel better. All right, cystic fibrosis, again, Pam's topic. This is a hereditary disease. So, salt, something happens with our chloride transport. The mucus has less salt, so water follows salt. So you retain less fluid in that mucus. Mucus is very, very important in the body's immune system. Mucus does a lot of things for our body in terms of immune defense. Cilia are important. Mucus is important. Constriction is important. And so when that becomes disrupted, it really sets these patients up for a lot of medical problems, and we teach this as part of pulmonology because one of the first places that we see this is in the respiratory system in the form of frequent pneumonias. Failure to thrive, cough, a little bit of hypoxia. You can hear some crackles. Got this salty skin, right? We had a GME director when I was at Madigan. He was there forever. He had 5 kids. All 5 of them had cystic fibrosis. I know. It was, why did he keep having kids? It was the weirdest thing. Like, there was almost like an ethics board at some point. It was just the weirdest thing. Why does this guy keep having, yeah, it felt weird. Okay. Like a Munchausen's, right? It was just bizarre. Anyways. I mean, you don't want to tell people not to have children, right? Alright, so diagnosis. And mucus will be thick. It will not clear. So you'll see some plugging. If you are not able, if you plug up the lungs and you can't get air to them, those alveoli will collapse. So atelectasis can be seen in these patients. Ooh, ABGs. Look, we already used our ABGs. So, unable to ventilate our CO2 to get it out of our body effectively. So primarily, we'll see patients with respiratory acidosis because they're not venting the CO2, but because it's chronic, typically their kidneys will have already upregulated the retention of bicarbonate to compensate. So not necessarily be out of normal range for their pH because they've had kind of time to adapt to it. Our PFTs, right? So this is not focal in the upper air, or not focal in the bronchi. It's everywhere. So in general, we'll see a mixed pattern. So it affects the flow of air, and then it also affects the lung's ability to take capacity of air. So pilocarpine test, so this is the test we do. I don't think we'll ever order this. So if this is something that's of concern early on, it's usually done by a pediatrician. I don't think we'll ever catch it in active duty population, but I bet you it's happened. Someone that, phenotypically maybe doesn't have a severe disease, hasn't ever been picked up, but it's probably not going to be common, but it could happen. So this is how you need to test for it. If you're very, 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 very sure that they have every symptom and they probably have it, the normal test does not exclude it. It's not like that, what was that one, the methacholine challenge, right? Where if that's negative and it's done right, you don't have asthma. So it doesn't exclude it, so they'll have to do full genetic testing afterwards. This is a typical patient. Again, we said Caucasian, they usually diagnose it earlier, usually male. Treatment goals, because treating this, lung transplant, I've known patients that have had lung transplants, it doesn't really, it's 50-50 in terms of 3-year survival. But in the meantime, screen family members, have conversations about the likelihood of having another child with cystic fibrosis and what that means, and then make sure that you are doing everything you can to prevent those frequent and repeated pneumonias, because that's really what's going to cause a lot of their disability, a lot of the morbidity associated with cystic fibrosis, is because they keep getting infections in their lungs, and over time that causes the lungs to not function as well, leading to some of that mild hypoxemia. All right, so we give them some mucus thinners, antibiotics, a lot of antibiotics for these patients, and then things that cause, maybe I should put COVID in parentheses, right? I don't know, but considering, helping prevent some of those common causes of pneumonia. Average lifespan is 44, which is up a lot than data from about 20 years ago. I think it was in the high 30s. And these are the reasons. We'll talk about respiratory failure, pneumonia, core pulmonale in subsequent lectures. This is our last topic, I think, bronchiectasis. This is a new word. Bronchi means airway, ectasis means widening. So this is a permanent abnormal dilation of the bronchi. So the bronchi are too wide. You look at this picture here. When we talked about physics, we talked about how air flows in and flows out, and it depends on the resistance in the airway in order to make that movement in and out of the parenchyma of the lungs. So when they're abnormally dilated, that affects the flow of air. So it is a type of obstructive airway disease. It's similar to COPD, which we'll be talking about. The stereotypical patient is a woman in her 60s. So stereotypically, so usually PANTS questions or coronal polyps test questions, that was my phone, sorry. Coronal polyps test questions will usually have this type of patient. That'll be a clue. Sorry. Wow. I had so much coffee today. All right. So, most common, pathophysiology. Okay, this is, so how does this happen? Where does this come from? There's a couple different reasons that this happens. We've got people who have recurrent infections. So we will probably see this, right? We'll probably see cystic fibrosis come up. Oh, there it is, right? Recurring infections can cause this. Airway obstruction, recurrent airway obstruction can cause this, and fibrosis. So something happens, causes damage, and the result is that we have these abnormally dilated bronchi. So it's fixed, and then what happens is we've got this mucus that can't clear. So when things sit and they don't clear, like when you're holding your pee in the field for 2 days and you get bladder infection, right? So it's like when you have eustachian tube dysfunction and your ears don't drain, and then you get an ear infection. It's like when you have sinusitis from a virus and your sinuses don't drain, then you get a sinus infection. So when things don't drain and they sit, like that mucky pond, not that pretty river, you get infections. You get pneumonias. And then because they're all widened and they're floppy, sometimes they'll also intermittently collapse. So these are the signs and symptoms: lots of coughing, lots of sputum. Diagnosis is made by chest CT. If you're have a patient that comes in, chronic cough, they've had a cough for 2 months, 3 months, 6 months. This was my mom. She actually got diagnosed with it. That's on her. But she had this cough forever, and it was so annoying. And it was like, my dad smoked cigars, and so we're like, quit smoking cigars in the house. And we sent her an allergist, and she did all this stuff. She ended up in the hospital with pneumonia. They had to put chest tubes, or not chest tubes, well, drains. And afterwards, they got a CT on her, and come to find out she had bronchiectasis. So she, again, we were giving her all these, I was giving her all these prednisone dose packs and cough suppressants and nasal sprays, and it wasn't helping. Come to find out, you don't want to do that for these patients. You want them to cough that stuff out as best they can, which sucks for the patient, it sucks for the people around them. But we really want them to be able to cough that out so it doesn't sit down there and become infected. And then giving them, so she started doing exercising and started doing upper stuff just to help, you know, it's almost like a breathing treatment, right? You want to help your lungs, doing specific exercises to help move that mucus out of that airway. We also use antibiotics, and then less well studied, she is actually on a bronchodilator too, and it's helped. We'll talk real quick about these. These are going to be like our thumbprint for croup. They're going to be like our steeple sign for RSV. We'll talk about what these are real quick on the next slide. So tram tracks, we talked about, remember, let's look at this picture real quick. Abnormally dilated. They're gonna look bigger. They're not gonna look normal. When you look at them straight on, let's look at this one over here. When you look at them straight on, you're gonna see that dilated bronchiole, right? And when you look at them from the side, they call them tram tracks, man, this one's hard to see. But you can kind of see them on this one, right? So those are tram tracks. You're looking at that bronchiole from a side, from a horizontal, yes, perpendicular, yep. And here you're looking at perpendicular. So we call them tram tracks when they're horizontal, and we call them signet rings. Well, you took radiology. You learned this. Okay. Sorry. Review. And do you remember why they call them signet rings? Because of the little vein in the artery. Okay. All right. So there's our little signet ring. And that's it, guys. Woo-hoo.